Today I'll be presenting a case of a 52-year-old male patient who presented with alleged history of DS, deliberate self-harm, by consuming 7 tablets of Quteiapine of 100 mg strength. And he was brought to ER. On initial 10-second assessment, airway was patent, no pooling of secretions or gurgling of sounds. Breathing-wise, air entry was bilaterally equal, saturation maintaining at 98% on room air, and respiratory rate of 16 per minute. Circulation-wise, BP was 110/60 and heart rate of 86 beats per minute. Capillary refill time of 2 seconds, and disability-wise, GCS was E3V4M6, 13 out of 15 GCS. Pupils were 2.5 mm equal and reacting to light. GRBS of 182 mg per deciliter, and exposure-wise temperature of 98.4 degree Fahrenheit. No external injuries as such were noted. Adjuncts to the primary survey, ECG taken showed a normal sinus rhythm with a QTC interval of 469 milliseconds, and VBG taken showed a pH
normal
of
QTC?
Normal QTC for male and female is different. For male it is 480.
480. This is
469.
469. Almost normal.
And pH, VBG pH showed metabolic acidosis with a pH of 7.332 and a bicarb of 20.4. Lactate was 5.1. So it was a lactic acidosis.
What do you think? Why the patient should have lactic acidosis in this type of cases?
Lactic acidosis can be due to this Quteiapine can cause hypotension. So that reduced perfusion can cause
reduced perfusion can produce.
There can be extrapyramidal side effects of like dystonias, uncontrolled involuntary muscle contractions.
Rigidity, involuntary movements can also produce lactic acidosis. Other one?
And
seizures. Seizures. One of the most important problem of Quteiapine overdose can be seizures also. Okay. Renal failure is not there, so seizure you should suspect. Overactivity of muscles you should suspect. Hypertension you should suspect.
Okay. Coming to secondary survey, sample history: a patient, 52-year-old male patient, presented with alleged history of deliberate self-harm by consuming 7 tablets of Quteiapine of 100 mg strength. Bystanders had found him lying on bed unresponsive, and he was taken to the hospital here. And while in the ambulance, his sensorium mildly improved, and that time he had confessed that he had consumed these tablets. There are no history of any seizures, syncope, palpitations, fever, blurring of vision, agitation, other drug intake histories, or trauma.
Fever, why we are looking for?
Fever because these drugs can cause dopamine receptor blockage, which can cause neuroleptic malignant syndrome. Can be present. And allergic history, no past allergic history is there. Medications, he's on Quteiapine since 10 years, and he's on ecosprin, atorvastatin, and glargine insulin. Past history of type 2 DM, type 2 diabetes mellitus, hypertension, and coronary artery disease, post PT, percutaneous sinus, as post ending. And patient initially had arrived within 2 hours of intake. The bystanders had noticed. Within that time itself, they brought him to the hospital. So within 2 hours itself, they had brought him from that unresponsive state. But the correct time of drug intake wasn't known. The patient also doesn't remember about the exact time. So since the patient presented within 2 hours, we had started the patient on gastric lavage, and activated charcoal was given. 50 gram of activated charcoal single dose was given. The preparation was also not a sustained release preparation, so only single dose activated charcoal was given.
What is multi-dose activated charcoal?
Multi-dose activated charcoal is when the patient has taken a large amount of the drug, or the patient has taken a sustained release preparation of the drug. So the time in the stomach it will be more. So we can give a single bolus dose, followed by after that we can give repeat every 1 hour, 2 hour, and 4 hour. We can repeat 12.5 gram. We can repeat. So that is a multi-dose activated charcoal. And in this patient, this GCS we had assessed, but he was able to maintain a patent airway. So he was a bit on the drowsy side, but he was responding to verbal commands. So we had we went ahead because the airway was okay. Otherwise, we have to avoid in the circumstances the patient is having a patient is drowsy or sedated, and patient can't protect the airway. We can avoid giving the lavage and active charcoal. And after that, we had sent the samples, toxicology samples of blood, urine, and gastric aspirate sample for the said compound Quteiapine, and also for other co-ingestants had also been sent. Then after that, basically this compound Quteiapine is actually second generation antipsychotic, and it is the overdose causes three main actions, which is one is histamine blockade. So that will cause the sedation and drowsiness, and then there is alpha adrenergic blocking action that is responsible for the peripheral vasodilation, which causes the hypotension, and also that can cause
what is the peculiarity
meiosis
of this hypotension?
It's orthostatic
alpha adrenergic blocking produces hypotension. So what are the drugs you can start for this patient when you have hypotension? What are the preferred drugs?
So first in hypotension, we'll start with crystalloids. Fluids. So 10 to 20 ml per kg. We can start bolus, and maximum up to 30 ml per kg we can bolus. Then not responding, then we have to start the patient on vasodilator like norepinephrine preferably. Epinephrine should be avoided because it has additional beta 2 activity which can cause further vasodilation.
Is one drug which should be avoided in this situation. Where you can routinely we use norepinephrine only. Yes. We have to be very careful to use epinephrine.
So then after that, that is for hypotension. Then other effect is the muscarinic blockade action. So that will cause anticholinergic features like hot flush skin, dry skin and mucous membranes, altered sensorium, sedation with intermittent agitations, and also mydriasis will occur. So reduced blurring of vision or reduced vision will be present. So those cases
what happened to the heart rate?
Heart rate also will be on higher side. Tachycardia.
Something like atropine. Dilated people, tachycardia.
Anticholinergic toxicity.
Dryness.
That can also be present. So basically the management is conservative management in Quteiapine.
What other things you have to see? The
ECG. ECG we have to take. We have to see for QTC prolongation. But it's less likely to happen with Quteiapine. More
QTC prolongation is common, but Torsades point is less common. So QTC is very commonly you can see, but not Torsades point. Normally drugs will lead to Torsades point is in QTC prolongation.
And then after that we have to, after decontamination and if there is any hypertension, we manage hypertension. Then if there is any CNS effects, we have to see if the patient is able to protect airway. Otherwise ABCs we have to stabilize first, and after that if the patient is agitated and all, we can give benzodiazepines. Otherwise if the patient is having seizures also, we can give benzodiazepines. So it's more like a symptomatic management, and other alkaloid abnormalities and all we have to correct. Any urinary retention the patient is having due to the anticholinergic features, then the catheterization has to be done. And also those are the main management.
Can we dialyze the patient? Is this toxin dialysable?
No. It is. It has actually a large volume of distribution and has more protein binding. So
fat binding. So it is not dialysable.
And also there is one drug, neostigmine, pyridostigmine, which is acetylcholinesterase inhibitor. We can try in this patient because of the increased cholinergic activity. It can reverse the anticholinergic effects. But it's not a proven antidote as such. In research, it has not shown any obvious benefit.
Only thing you have to watch and symptomatically treat when there is hypertension, treat with noradrenaline and fluids. That is the main treatment. What happened to the patient?
Apart from the one more treatment we can give is intralipid emulsions. Can also be given. So we can give around 1 to 1.5 ml per kg of 20% lipid emulsion solution. We give over 1 minute, and we can then start on infusion. As well, 0.2 to 0.5 ml per kg per minute we can give infusion.
What happened to the patient finally?
Patient right now we are giving psychiatric consultation for further management. Because right now patient has not developed any complications due to just the CNS symptoms of sedation, drowsiness was there initially. That has improved after 6 hours. It has
So what you understood from this case? Quetiapine overdose is nowadays very common. Okay, we are getting a lot of cases. No need to panic. It is only producing prolonged QT interval. Seizures are the most important thing, and hypotension. Hypotension, anyway, we are not treating with adrenaline, but we have to be careful not to give adrenaline. That can produce paradoxical hypotension. That is the main thing. Okay.